I am a pediatric neurologist, and I do both low tone and high tone children. So I do neuromuscular disorders, and I also do movement disorders. But today we're going to talk about children with low tone or hypotonia. And what I'd like to do is give you just an approach to how to think about these children, to look for the things that we really have specific treatments for. So can I start with just a question? How many people in the audience are general pediatricians? Most of the audience, okay. And how many neurologists? Only one, so I only have to watch for questions from one person in the corner, okay? And everybody else is another kind of specialist, so that's good. Okay, so I'm going to give you a pragmatic approach to children with hypotonia. And the goals are to recognize hypotonia and understand the difference between low tone and weakness, because they're not the same, and it's important to be able to differentiate them. So our goal is going to be to localize where the tone is coming from, and then from there we can worry about etiology and understand that there are treatments available now for many of these disorders. So let's first talk about strength. Okay, so even though we're going to focus on tone, let's talk about strength first. So strength is the ability of muscles to generate work. So for the legs, that means walking. For hands, that means gripping things. But it's the ability to be able to produce something that results in work. And in order to have the ability to do work, you have to have good tone, good strength. Okay, you really need both. And they're related, but again, they're not the same. When we talk about infants, we're going to find that hypotonic infants weak infants are almost always hypotonic, but hypotonic infants are not necessarily weak, and it's important to recognize that. Okay, so now what we really want to focus on is the discussion about tone. So tone is the resistance of muscle to movement. Okay, so you passively move the muscle, you can feel resistance or no resistance, okay? And you can have both resting muscle tension, which is phasic tone, which is the ability to maintain a posture, and then the phasic tone, which is when you pull on the muscle quickly, how much resistance do you get? And if you get lots of resistance, then that's not hypotonia. Okay. If you get resistance when you move fast, that's probably spasticity, which is a whole nother talk. And if you get resistance when you move slowly, that's more likely dystonia, which is a whole nother talk also. And we'll do that maybe next year. Okay. Tone relies on the muscle tendon unit. So it's not just the muscle, but it really involves the tendons also. And I have to admit, I've been doing this a long time now, and I don't think I understood that really very well until the last few years, that you realize how important the tendons are. And it's why orthopedic surgeons will often lengthen tendons as a way to reduce tone. Okay. Again, another talk for another time, but it does explain that the tendons are intimately involved in that. And then what you're doing is you're working between bones and across a joint, and the joint is the lever. So the joint is what allows you to change directions. All right, so where do we want our tone? Okay, I use this in the office every single day. I compare tone to spaghetti. Okay, and if you are too stiff, then you are uncooked spaghetti. And if you are too loose, then you are overcooked spaghetti. And where we want you is somewhere in the middle, what we call al dente, or slightly undercooked spaghetti. That's where your muscles want to be. That's their happy place, because that means that they are ready to go. Okay, and the reason I like using spaghetti is because I can explain to families, we have lots of things. If you have too much tone, we have things we can do for that. We can take away tone. Just like your spaghetti. If it's not cooked enough, throw it back in the pot, cook it a little bit longer. But if you've overcooked your spaghetti, just like low tone muscles, we don't have anything great to make your muscles stiff again. Okay, so tone, low tone is dealt with therapy and bracing and things like that. Okay, so I'm going to show you a picture, and then I'm going to ask you a question. Okay, so while you're watching that, how many think this little boy is weak? And how many think this boy just has low tone? I didn't see hands either way. Try again. Weak? Low tone? Both. Okay, so I want you to watch him get up. And this is a good thing to know in your office. When you watch him get up from the ground, okay, he's getting up with no hands, he can rise up. Okay, that is your easiest measure to tell you that he has really good strength in his quads. And this little boy is not weak. And he does not have a muscle disease. He truly doesn't even have a neurologic disease. This is a little boy who has a variant of Ehlers-Danlos syndrome where his tendons are very loose because his collagen is very flexible. Okay, so this is a good example of low tone without weakness, but he was sent to us because he was, quote, weak. Okay, so how big a problem is hypotonia? It's pretty common. I would imagine that in your office every week, every month, you see somebody with low tone? Yes? Yes? Common problem? Yeah, okay. So about 60 to 80% of it is brain-driven, and about 20%, maybe 30% is driven by the peripheral nervous system, the muscles and the tendons, okay? And there are lots of different etiologies that go along with this. Certainly in the newborns, we worry about children who have had birth asphyxia, a term I don't actually like very much. But often the chromosomal abnormalities make up about a third of the children that we see in the newborn period. But the ones I want to focus on are going to be really the peripheral ones because we have more to offer for those children. And for those, we're talking about disorders of the muscle, and we're talking about metabolic disorders that may affect the muscle, the nerves, the tendons. Okay? Questions so far? Okay, so when we think about how we're going to localize it, I just encourage you to have an organized approach. And whether that is top to bottom or bottom to top, it just depends how you like to think about it. I like to think top to bottom, but I have students that prefer to think bottom to top, and that's okay. Just make sure you cover all the bases. We're going to cover brain, we're going to cover brainstem, spinal cord, nerves, neuromuscular junction, and then the muscle/tendon together. Okay, so that's how I like to think about my differential when I'm looking at the child to try and understand, is this a brain problem or is this a peripheral problem? Okay, so what are the key elements about understanding the child with low tone? So first is when did it start? Did this start in the newborn period or before? When you ask mom, is this a child who didn't move very well before he was born? Is it generalized? Is it the whole body, or is it one part of the body or a particular segment of the body, particularly like is it legs only, which might lead you to think about spinal cord? Is it getting better, worse, or not changing at all? And then there are aspects of the history. First, is there anybody else in the family who's had this? Okay. And sometimes you have to be a little creative. They may not say yes, they have hypotonia, but you can ask, well, is there anybody who's struggled in school? Is there anybody who, did you have a relative that died when they were very young? Is there anything in there that would suggest that there's a family history? And I always ask if the parents are related. And I ask it in a way that, as a general question, I just tell them up front, I ask this of everybody. It's nothing about your family in particular. It's just something that we ask everybody because it helps us understand what's going on. And I've been surprised sometimes when we get the yeses that they are. particularly not necessarily from here, but particularly from Middle East and places, it's much more common. Okay, and then of course, are there other things that happen that we know about? Does mom have a muscle disorder that we should be concerned about? For example, does mom have myasthenia gravis? Does mom have myotonic dystrophy? These are things which we will see in the baby that are very important. Okay. Then obviously you're going to examine the child, and the muscle part of the exam is a given, but it's important to pay attention to the mental status. Is this a child who is intellectually or developmentally appropriate, or is this child delayed in some other way? Particularly, is there evidence of language delay? And by language delay, I don't just mean articulation, is it not just enunciation, but is their vocabulary really, really delayed? Because that's a clue that this is not a muscle problem, or at least not just a peripheral problem. It may be both, but that there's a central component. Same thing with sleep disturbances. Okay, does the child have dysmorphic features? Are there things that are obvious? Are the ears rotated back? Are they too low set? Is there anything about the face that looks familiar? Do they have the simian creases? Do they have the thumbs that you see in some of the trisomies? And then we go on to look at swallowing and sucking. How is that? And then obviously we look at the muscles themselves. Is the baby floppy? Is the baby weak? Does the baby have reflexes or not? Those are like the most important things. Okay, so these are pictures of a very, very floppy infant from an article written by the person who trained me many, many years ago. And this is obviously on the top is head lag. And then this is the head lag, and then the scarf sign where you can bring that arm all the way across, which you shouldn't be able to do in a baby with normal tone. The ventral suspension is on this side, and this one is, does the baby fall through your arms if you try and hold him by the shoulder? P.S. If you can do that, you better hold his chest because you don't want to drop the baby in front of mom. Okay. Based on all this information, then, we can begin to localize, is this a peripheral or a central problem? And the big thing is, with central problems, strength is generally normal. Okay, and that's a key point. So if you have a baby with a sleep disturbance, with language delay, whose strength is normal, this is not likely to be a muscle problem. And then on your exam, you're going to find that they have normal reflexes or maybe even increased reflexes. They don't have to, because children with cerebellar problems can have no reflexes. Okay, and sometimes children with tethered spinal cord may have no reflexes, at least in their legs. And so that's a good way to help differentiate what's going on. Okay. And then as you work down, you can see that the reflexes are generally normal in central problems and normal if it's in the neuromuscular junction, like myasthenia gravis, like congenital myasthenia. Otherwise, they're generally decreased or absent. And if they're increased, that's clearly a sign that this is a central problem from the brain or the upper spinal cord. Okay, just some quick examples of brain things that give you low tone. On the far side, that is what we call lesencephaly, which is a simplified brain. We used to not really understand this, and now we know that there are many, many genetic disorders that can result in lesencephaly, and I suspect that the epilepsy talk included some of the genes that have brain malformations as part of their epilepsy. Congenital infections like CMV, toxo, we don't see them that much anymore, but they're out there, and they're important because there actually are some treatments now with antivirals that we would not have done years ago. And of course, HIE, and the important thing about HIE is differentiating it from metabolic disorders. So I'll be honest with you, if I'm seeing babies in the nursery, I actually do not use the term HIE in the nursery. I use neonatal encephalopathy, meaning that this baby meets all these criteria, but I don't really fully know why yet. So I tend to be cautious about using the true term HIE because I think it makes us stop thinking about what might have actually happened, and I think we miss things when we do that. Okay. So again, here's the kind of a carryover from the previous slide about how we think about this. So again, central disorders, we want to think about looking at the brain with imaging. We want to think about looking at the genes in some way, and the way we look at genes is changing. When we did this slide, it was microarray, and then we added panels, and now I'm told if you do whole exome, we don't even have to do microarray anymore. They do it all together. So it's gotten simpler to cover more territory with genetic testing. Again, looking for dysmorphic features and things that might lead you to believe that there's a chromosomal abnormality or a clear gene abnormality. And then the imaging can give you guidance when you're looking for specific disorders. And then you get down to so we've gone from the brain, now we've gone down to the spinal cord, and now we're out towards the neuromuscular junction, where I put EMG and things up there. I will tell you, EMG in children is A, difficult, and B, rarely that helpful. Genetic testing has obviated the need for a lot of EMG testing, and I know my muscle colleagues sometimes will think that's heresy, but I grew up doing EMGs. I have a partner that does EMGs, and I'm telling you, we really don't do that many of them, and almost never in infants. I won't say never, but pretty rarely in infants do we do EMG. It's just not that helpful. Okay, so again, this is just to summarize. Central things: global developmental delay, hypotonic but not weak, often disrupted sleep, encephalopathic and dysmorphic features, and peripheral. You're usually weak along with being hypotonic, although not always, as we saw with the youngster with the collagen disorder. They have normal sleep patterns for children, and usually, they're alert, they're not encephalopathic, and they have normal language development. So what I like to do is, now that I've localized, I want to think about things that are treatable. And I worry about them first, and everything else can come later. But I don't want to miss the treatable disorders. And our list of treatable disorders is growing. So obviously there are some structural things. If you have a child with hydrocephalus, or a child with a tethered spinal cord, or a child with a Chiari malformation, those are amenable to surgical intervention. May not solve all the problems, but that's a sign that those are things that need to be corrected, and those are clearly surgical problems. Okay. From the neuromuscular standpoint, spinal muscular atrophy, Pompe's disease, which is acid maltase deficiency, infantile botulism, and neonatal myasthenia all have very, very specific treatments. And you don't want to miss these children, because you can make them better, and you run the risk of actually having a child pass away unnecessarily if we miss the diagnosis. So these are important. Then there are a whole slew of metabolic disorders. And again, the list of these that's treatable is growing. Carnitine or CoQ deficiencies, rare but very treatable. Menkes disease has a limited treatment, and it's limited in its effectiveness, and it also has to be administered by 5 weeks of age. And finding one of these kids by 5 weeks is pretty hard. The one I saw recently came to me, and he was 2 years old when I saw him, and his diagnosis had been missed by several pediatric neurologists along the way. So that was discouraging. The organic and amino acidemias have dietary management. The neurotransmitter disorders have specific replacement therapies. And obviously the non-neurologic things, thyroid, PKU, and now a new one, which is Allan-Herndon-Dudley syndrome, which is a disorder of a thyroid transporter protein, has a new a treatment under development, and there's an expanded access program. We've just recently seen a child from Mexico with this rare disorder that's starting on treatment. So this is like, within the last year, this has become available. So it's constantly changing, and so it's important that we look at it. Let me talk briefly about spinal muscular atrophy. So this is a degeneration. This is, even though we think of it as a muscle disease, it's actually a spinal cord disease. Okay, 10 years ago, you see a child with type 1 spinal muscular atrophy, which is the early onset, and you counsel the parents that their baby's not going to survive to see their second birthday without mechanical ventilation. In 2016, that world completely changed. Okay, and we had the introduction of a new medicine to treat spinal muscular atrophy. So when you think of SMA, or spinal muscular atrophy, and I would imagine that in the course of your career, you're going to come across one of these children in your practice. They're relatively common for a rare and fatal disease. At least in the United States, this has now been added to newborn screening. So I don't know if it is here or not, but it's been added because we have treatment. And early recognition is important because their cells are dying off every single day. So every day that you delay is more weakness. So we classify this by the number of copies of a backup protein they have. And I'm not going to go into a lot of detail about SMA, but suffice it to say that there is one piece of the protein called survivor motor neuron protein that is missing. Okay, but we have a backup copy that's almost perfect, but not quite. It has one little piece that's not quite right. But the number of backup copies that you have determines when you're going to present and how weak you're going to be. To some extent, it's not perfect, but it's pretty good. So if you have no backup copies, these babies are stillborn. But if you have one backup copy, the babies are very, very weak and may or may not respond to therapy. They probably will respond to gene therapy, but they're going to be very weak. Most of the babies that you're going to see in the nursery are going to be type 1s with 2 backup copies. And then the more backup copies you have, the later they present, and they can even present in adulthood. This is what it looks like. Again, on the light green is your primary copy. The darker bluish green is your backup copy, and that's where we had our initial treatment. And the treatment that we initially had is an RNA-based treatment. There are now 2, but these have to be administered over and over. One of them is an oral medicine that's every day, and one of them is given by spinal tap every few months. You get 4 initially over a couple of months, and about every 4 months after that. But it's a forever therapy, and it's all very expensive. I mean, a lifetime of therapy in the United States for these children is $25 million for the drugs. So they're crazy expensive. Okay, so what's better than that? It's $150,000 per dose. Yeah. So what do we have now? Now we actually have a gene therapy that goes to your DNA. Okay, so this is a one-time intravenous infusion to replace the missing gene. Okay, it's not 100% perfect by any stretch, but this is one time. It doesn't preclude you from using the other therapies later if they're not responding, but this is how far we've come in the course of just a few years. So we find these babies on newborn screening, and we have them hopefully in within 2 to 3 weeks and are treating them with this gene therapy. We try and move that fast with them if we can. Okay, so just some examples of muscle disease. This is kind of for older children. So on the far left, this is the later onset spinal muscular atrophy. You can see the weakness that he's got along with his hypotonia. I don't have a video of him getting up, but it's a classic Gower's maneuver. He goes to get up, and he's doing this to help himself get up because he doesn't have the leg strength. So remember the first video I showed where that child was able to like pop right up? These children can't do that, and that's your clue that it's the muscle. Okay, these children, the ones with SMA, let me see where there we go, have normal looking muscle. That big leg should be a clue. Okay, that leg is something that I think every pediatrician would recognize, but I'm surprised how often pediatricians miss it. Not here, I mean everywhere. In fact, I've talked to the companies about helping recognition, and I say, I think actually instead of directing your efforts at the pediatricians who are going to see one of these children in a lifetime, direct it to the orthopedist and the physical therapist, because these kids get referred in because they're not walking right. They may not know what's wrong, but they send them to the orthopedist, and our orthopedists don't do anything until we've seen them. They won't operate on these kids. They don't do biopsies. I can tell you a number of these kids have ended up in the GI office because their liver enzymes are elevated. Why? Because those same enzymes are in the muscle, and we don't look at the muscle enzymes. So we have worked very hard with our gastroenterologists. Any GI people in the office, in the clinic here today? Okay. When you talk to your GI friends, if they call you and say they're going to do a liver biopsy, please ask them if they've done a CK first. And if the CK is sky high, they don't need to get the normal muscle, the liver biopsy. It won't give us an answer. Okay, and then myotonic dystrophy presents from mom, presents in the babies. They're very weak. And what's an easy test to screen for myotonic dystrophy? Go up and shake mom's hand. okay? When mom shakes your hand, if she can't let go of your hand, if she can't open up her hand, think myotonic dystrophy and think it in the baby. The babies will not have myotonia, but mom will. And if you then go and thump on mom, you'll thump on her and her thumb will get stuck like that. And you will have made your diagnosis before you do any tests. You'll already know what's wrong with the baby. Okay, very, very simple. Okay, all right. I bring up muscular dystrophy not so much because it's low tone, but because I want to point out that we did not have treatment for muscular dystrophy either until a few years ago. And now we have a multitude of genetic treatments for muscular dystrophy. Again, some are RNA therapies that have to be given every week, but we now have a gene therapy for many of the boys with muscular dystrophy. In the United States, it just got approved for 4- and 5-year-olds only. 6- and 7-year-olds are probably next. It's not for all of the boys, but these therapies are coming. And so it's more and more important to recognize the treatable causes of hypotonia. Okay, so again, we've gone through the diagnostic evaluation, history, physical, imaging, labs, genetics. We're moving away from panels and towards whole exome because we get more information, although every genetic test misses something. None of them are perfect, okay? This is a common problem that you have already told me you all see in your office on a regular basis. There are both neurologic and non-neurologic causes for it. It can be static, progressive, sometimes self-limiting. The key is localizing where it is. You don't have to, I'll be honest with you, as a general pediatrician, you don't have to know what it is. Just know where it is, know that there's something wrong, and know that you need to ask for help. And there's nothing wrong with asking for help. We all ask for help. I'm lucky. I have 14 partners I can ask for help if I don't know what something is. But there's nothing wrong with asking for help, and there's nothing wrong with referring. And in fact, it will help you make better referrals because you will have pre-screened them for things, and you'll know what your question is. Okay. Management is dependent on knowing what the diagnosis is. Again, you don't have to have the specific diagnosis, but I'll bet several of you walk away with some new thoughts about diagnosis on kids you've already seen, and you'll go home and relook at these kids. And then if they have a specific treatment, great. If not, we can do symptom management with bracing, therapy, support. Genetic counseling is important, and managing the family's expectations. And again, I will just reiterate, look for the treatable disorders first. Everything else can wait. And with that, I will be glad to take some questions.
Bueno,